So this is a case of RF AF ablation. You can see that the pulmonary veins have been circumferentially ablated at the antrum, and then the roof line has been performed to prevent roof-dependent left atrial flutters. So some of the drawbacks are that it is slightly time-consuming when compared to cryoablation and pulse field ablation. However, with high-power short-duration ablation, the duration of RF ablation has significantly come down. So increased procedural duration and fluoroscopic times, and there is a risk of pulmonary vein stenosis, phrenic nerve injury, and atrioesophageal fistula, which has a very high mortality. So we have to be very careful when ablating on the posterior wall where the esophagus is situated. However, with high power short duration ablation, the risk of esophageal injury is significantly less. So coming to recent advances in RF ablation, we have got contact force sensing catheters, which tells us whether the catheter is in contact with the myocardium or not. So contact force of more than 10 grams suggests that the lesion is quite durable. And another advancement is the novel strategy of high power short duration ablation, where we use power of more than 50 watts for a few seconds, say 6 to 8 seconds, for achieving a durable lesion. So these are the catheters, the contact force sensing catheters. So there is a sensor at the tip of the catheter which tells us whether the catheter is in contact with the myocardium or not. So this has significantly increased the efficiency and efficacy of pulmonary vein isolation. And coming to high power short duration ablation, so you can see here the lesion becomes wider and less shallower with high power short duration. Whereas with medium power, medium duration ablation, the lesion depth increases and can cause collateral damage to the phrenic nerve and the esophagus. So this is one study which has shown that high power short duration ablation was significantly better, had a significantly higher efficacy with respect to AF recurrence, and it was safer when compared to conventional ablation. So coming to the next modality of ablation, which is cryoablation, where we use liquid nitrous oxide at high pressure, so which by means of Joule-Thomson effect causes cooling and freezing of the myocardium. So at a temperature of minus 30 degrees, it causes reversible freezing. And this can be utilized for the purpose of cryo mapping. You can map by reducing the temperature to minus 30 degrees and see what is the effect. If it is beneficial, then you can further reduce the temperature and cause irreversible freezing, which is called as cryoablation. So cryoablation is the only true single shot device for AF ablation. So this is the latest generation cryo balloon. So this is the Arctic Front Advanced Pro catheter. So the balloon comes in two shapes, 23 mm and 28 mm sizes. So the balloon is placed at the antrum of the pulmonary vein, and the balloon is frozen. So that causes circumferential isolation of the pulmonary veins with a single shot ablation. So compared to RF ablation, where you get a very irregular kind of a lesion, with cryoablation the lesion is quite homogeneous and no scar tissue beyond the margins of the lesion. The lesion is quite well demarcated compared to the normal myocardium. So this was the landmark fire and ice trial which showed that cryoablation and RF ablation were equivalent, and cryoablation had the significant advantage of lower procedural time and lower fluoroscopic times, because the cryoablation is far more simpler when compared to RF ablation. You have to just take the balloon, achieve that there is good contact with the pulmonary veins circumferentially, and then freeze in that area for say 3 to 4 minutes. So that causes durable isolation. So cryoballoon has also been investigated as a first-line strategy for atrial fibrillation. With respect to RF ablation, generally we wait for multiple recurrences, at least one recurrence on medications for ablation. However, cryoablation, being much safer, can be offered as a first choice treatment modality for AF. So these were some of the trials: the cryo first, the stop AF, and early AF. So these were the three major trials which showed that cryoablation was significantly efficacious. So I'll just go to the results. Yes. So you can see here, when compared to antiarrhythmic medications, patient presenting with first episode of AF, they had significantly lesser recurrences of AF with cryoablation when compared to antiarrhythmic medications. So all the trials showed consistent results. So the quality of life and symptomatic benefit was also better with cryoablation, and the cryoablation was also was similar in terms of safety endpoints when compared to medications. So the complication rate was 3% in the cryoballoon arm versus 4% in the medical management arm. So coming to the meta-analysis, so all these studies have shown that cryoablation is superior when compared to antiarrhythmic therapy as the first line treatment modality for atrial fibrillation. So I'll just skip some of these slides because of the shortage of time. I'll just show one case of cryoablation where we had done 1 year back. So this is a patient who had undergone bypass surgery for coronary artery disease. Then he came with persistent atrial fibrillation with fast ventricular rate, and he also had CML and was in remission on imatinib therapy. Patient was initially started on sotalol, but then patient did not respond to sotalol. He had recurrences, and then we took up the patient for cryoablation. So this is the fluoroscopic image of transeptal puncture, and then we take the achieve mapping catheter through the cryoballoon, and then I'm not sure whether you can appreciate the cryoballoon here. So at the left superior pulmonary vein, you can see the balloon being inflated, and once we achieve a good contact circumferentially, we freeze. And so you can see here we have given a contrast to show that there is complete isolation of the complete anatomical isolation of the pulmonary vein. And then once we freeze here for 3 to 4 minutes, that causes a durable electrical pulmonary vein isolation. So this is the left inferior pulmonary vein,